Hello, good evening, everyone. So, just coming to continue on the ventilation series classes. We're going to talk about advanced neonatal ventilation. So, part one of the module. So, divided into two modules. Initially, just going to talk about high frequency ventilation and basically very basics into it to see what exactly it means. And then the next module will cover how to adjust the ventilation based on the clinical scenarios. So basically, what is it? How does it work? Who does it benefit? What are the babies? What are the indications? And practical aspects and complications of high frequency ventilation will cover in the both the modules. So, and basically question comes, what is and how is it different from the conventional mechanical ventilation? See, when we say conventional mechanical ventilation, we talked about in the last two lecture series about SIMV, SIPPV, VSV, when pressure ventilation, volume ventilation. One of the main worry we all have as clinicians is about the trauma to the lungs because of the excessive pressure or excessive volume for these very tiny, premature or newborn lungs. Okay, so the whole idea is to see if in case any baby needs more pressure, more volume to achieve adequate ventilation or to achieve adequate oxygenation. When I say ventilation means carbon dioxide clearance or oxygenation. So when you're struggling with either CO2 removal or when you're struggling with oxygenation, then we end up in increasing the pressures for these babies. But when we increase the pressures, obviously it can cause border trauma. If you are increasing the volume, it can cause volume trauma, which are both proven to be very bad for the newborn developing lungs, which can lead to bronchopulmonary dysplasia. So that's where the high frequency ventilation comes into picture. See, it is about opening these lungs with minimal pressures at a fast rate so that the CO2 clearance and oxygenation can be achieved. So basically, it's all when the research has been done, it's all started inspired by the nature, the dog who is like panting, or the birds who breathe very fast, the dragonflies which breathe very fast. And so the frequency, basically it's all about high frequency with the low pressure, achieving the carbon dioxide clearance and oxygenation. So simple words, I would say it's like a CPAP with a little bit of wiggle. So you don't take it out. I just want to show you how it looks like. If, see, this is a histopathology slides of a rat lung. If you look into it, this video showing about normal ventilation. As you can see, this is normal respiration as we do. The alveoli doesn't collapse much. That's like the surfactants inside the alveoli allows us to prevent the collapse of these alveoli. So these are the babies with RDS. This picture. You can see when you do conventional mechanical ventilation without giving much positive and expiratory pressure. So every time the lungs have to open up completely alveoli and then completely collapse. Okay, it is a picture of the initial RDS when you don't give CPAP or when you don't give surfactant. Okay, so when you give some PEEP and surfactant, this is what happens to it. They try to open up, but you can see there's some overstretching happening. It prevents the collapse, but there's some overstretching happening. And this is what actually happens in the high frequency ventilator. It prevents the collapse of the alveoli and continuously just goes with a little bit of pressure to keep the alveoli open. So basically just another video to just give a visual picture for us how it works. So this is the conventional ventilation. When you see, observe all the parts of the lung. There are some lungs, like some part of the lung which remain unopened. Gases. See, this part is opening up, this part is not opening up fully. This is a conventional ventilation. Okay, we'll shift it to the high frequency ventilation to see what happens to it. We'll change it to the high frequency ventilation now. Slowly, you can see by increasing the pressure, the lungs are slowly recruiting. Even the previously atelectatic part of the lungs started opening up. It gives a very uniform pressure to the lungs. Okay, the lungs doesn't collapse, and every part of the lung is opened up, so prevents atelectasis. So the ventilation perfusion mismatch is minimized with this type of ventilation compared to the conventional mechanical ventilation. Okay. So, as if you all remember this pressure volume curve, when you increase the pressure in the first part of the pressure volume curve, until certain amount, the volume doesn't change. The pressure volume doesn't change much in the inspiration. Okay. After the pressure is increasing, the volume, the lungs open up, and then they go into the peak, the plateau phase, where even increasing the pressure, there is no change in the volume. So we want to ventilate your lungs somewhere here in this area, ideally between the what is called the green zone, which is a safe zone. Either you under recruit the lungs or over recruit the lungs. That is the injury zone. If you are ventilating these lungs in this particular zone, either big with high pressures, achieving not able to achieve much volumes, or low pressures where the lungs are getting de-recruited. Both these areas are dangerous and can cause injury to the lungs. So during CMV, both in the inspiration and expiration, both the phases, at one point of time, the lung is exposed to injury, both the injury phases from the inspiration and expiration. Okay. During HFO, the entire cycle operates in the safe window on the green zone. So basically, they look at the blue thing here. So there is no, the pressure is not changed hugely. It's just the frequency that changes. It goes fast. Okay. So what are the elements of high frequency ventilation? We have an amplitude, which means the amount of, simple to remember, the wobbling of the chest, amount of air, the swing of the chest that needs to be achieved to achieve the adequate ventilation and oxygenation. Okay, and then the frequency, how fast you want the ventilator rate to be for the frequency. For example, a frequency of 10 means 10 times 60, 600 breaths per minute. Frequency of 15 means 15 times 60, 900 breaths per minute. Okay, so there's a frequency and the mean airway pressure, the pressure that keeps the alveoli or lungs open. So basically, it's as you said, 600 breaths per minute. It's the physiological respiratory rate. The tidal volume here is almost, it's only very little. It's only about, it's less than the dead space. The expression here is active. Expression is not controlled by the ventilator. And oxygenation and ventilation can be separately controlled with this type of mode of ventilation. So how does a gas exchange happen during high frequency ventilation? It happens by various phases. So one of the things is what is called, because of the turbulence, because of the high frequency, the air molecules go through the airway into the distal bronchi and bronchioles and then alveoli. Okay, so the gas exchange happens at this level because of the turbulence here with the diffusion, and also happens diffusion level in the alveoli. There's something called a pendulant effect. It happens exchanging between two alveoli. For example, this alveoli is not opened up fully. Because of this ventilation, it helps, the pendulant effect helps both the alveoli to remain open during the ventilation. So, and some ventilation in the closed alveoli, there are direct pressures goes into the lungs. So there's a direct ventilation, there's a pendulant effect, there's a diffusion mechanism, and all the way through the airway, there is a laminar flow, and during the laminar flow itself, the gas exchange happens. Okay, so it happens at the airway level and at the alveolar level. At the alveolar level, mainly the diffusion, and at the airway level, convection, the mainly that happens. So by this high frequency ventilation, we can achieve the CO2 clearance both by convection method and diffusion method. Oxygenation mainly happens in the diffusion method. So as we said, it's because of the high frequency, the expiration thing is not controlled by the ventilator. In conventional mechanical ventilation, it's an inspiration, expiration, both are controlled by the machine. Here, the high frequency ventilation, expiration is free from the ventilator. So along with the turbulent airflow that happens during the inspiratory phase or continuous phase from the 600 breaths per minute, whatever the frequency. So the gas escapes independently of the settings. Expiration is not controlled in the high frequency ventilation. Okay. So what are the different machines we have to provide high frequency ventilation? Even the simple baby machines like Jaeger Baby Log 8000 plus, most of even the smaller units have it, can provide high frequency ventilation. SLE 5000, the newest ones, or Sensor Medics, which is very powerful high frequency oscillatory ventilator, which is used for mainly for bigger babies, and in the in the smaller infants up to 4 to 6 months, up to 10 kilos, this machine can be used, but to achieve if you want the high frequency oscillator. Okay, so basically when you want to start the baby on high frequency ventilation, high frequency oscillator ventilation, so you want to set 4 parameters. One is mean airway pressure, the frequency of ventilation, amplitude of ventilation, and FiO2. So as we said, amplitude of ventilation is mainly dependent on the wobbling of the chest. We'll come back to that in a minute. And frequency we'll discuss, and the mean airway pressure. These are 3 parameters we need to decide how to start and when to start and how to set them. So how to initiate the mean airway pressure? Basically, you want to initiate the pressures. Normally in conventional ventilation, as we discussed before, we started with the peak inspiratory pressure around 20 and the positive and expiratory pressure around 5 or 6. Okay, and once you start increasing the peak inspiratory pressure, it can go up to 20, 22, 24, 25. At particular stage, we as a clinician feel this is not good for the baby's lungs. So general tendency is once you cross a pressures of more than 22 in a preterm baby or more than 25 in a term baby, if the baby is needing that much amount of pressures, that's the best case scenario where you want to consider high frequency ventilation, because it will help in both ways. One, it's increasing the amount of it increases the respiratory support that you can provide, at the same time minimizing the trauma to the lungs. Okay, so when you want what is the number you want to set the mean airway pressure to start in a when you first initiate the ventilation, high frequency ventilation. So generally we say we start 2 centimeters above the mean airway pressure in the conventional mechanical ventilation. In the conventional mechanical ventilation, we say PIP of 20 and a PEEP of 5. The mean airway pressure generally stays around 10. Okay. If the mean airway pressure is more than 10, then you want to go for the high frequency ventilation. When you start the high frequency ventilation, you start 2 pressures above the main airway pressure in the conventional. So you start at 12. Okay. The starting pressure for a preterm baby, I would say 12. For a term baby, around 14. For a mean airway pressure, but ideally should be managed according to the settings what the baby was on before changing from conventional to mechanical ventilation. You add 2 to the mean airway pressure. So that is the starting mean airway pressure to the the lungs. So as if you increase the mean airway pressure, the lungs are going to open with high frequency ventilation, just like a typical RDS baby, and it's opening up with the ventilation. If you don't do it properly, it can actually overexpand the lungs. Even with the high frequency ventilation, there is a high risk that you will still cause overexpansion of the lungs and cause volume trauma. So we as a clinicians, when you initiate high frequency ventilation, it is our responsibility to stand bedside and find at the same time more regular monitoring, both on the C12 and the X-ray, that will help you to identify or adjust the mean airway pressure according to the baby's clinical condition and X-ray findings. Okay, so yeah. Sorry, guys. Then comes to the amplitude. When we say amplitude, the wiggle or how much air is going inside the into the lungs, to which is equal to in the conventional ventilation we say tidal volume. Here it's indirectly coming to the amplitude of the frequency ventilation. The amplitude in the proximal airways is going to be very high, and as we go more distally in the trachea and alveoli, the amplitude is going to be low. Amplitude also the same thing happens to the pressure. Amplitude here, the pressures here in the proximal are going to be very high. Mean airway pressures in the alveoli are going to be less. With this concept of high frequency ventilation, it tells us that the amount of amplitude that's going into reaching the alveoli is very less compared to what we actually set. That means the amount of damage that can happen to the lungs can also be minimized by the adjusting by this high frequency ventilation. So what are the different factors influencing the MAP and amplitude? So as we said here before, if the size of the ET tube is going to be small, the pressure is going to be more inside the lungs, and also the amplitude can be is going to be low. When the length of the ET tube is long, length is going to be long between the ventilator and the alveoli, the amount of amplitude is going to be also be decreased. If the lung is very compliant, that basically the amount of pressure, the change in volume with the amount of pressure is going to be high. Again, with each change in the unit of pressure, there's an increase in change in the volume of the lungs. So when we set mean airway pressure, we said we started around 2 centimeters above the conventional ventilation. Once we start with the map 2 centimeters above previous map to the conventional ventilation, usually between 10 and 12. Once we increase the map, as long as oxygenation is improving. So how stand bedside if the baby is oxygenating very well, that's fine. You can stop there at that point. If the babies are not oxygenating with the amount of the mean airway pressure that you have set, you need to adjust the map at each time by 1 centimeters pressure. So one increase in number 1 as long as oxygenation is improving. So it is ideal to have an X-ray that will help you to that will guide you to adjust the pressures, the mean airway pressure in the lungs. So if once you do a chest X-ray, the main thing that you want to look at is the position of the diaphragm. If the diaphragm is above the 9th rib, that means you are under recruited. That means the lung is still not opened up fully, in which case you want to increase the mean airway pressure. Okay, if ideally it should be at the 9th rib, you can continue the mean airway pressure. If the diaphragm is below the 9th rib, that means you are overinflated the lungs. You want to decrease the mean airway pressure. At any point of time, if you are seeing any changes of pulmonary interstitial emphysema, in the chest X-ray that tells you that already your over distension is happening and there is emphysematous changes happening in the lungs. Please decrease the mean airway pressure. So these changes in the opening of the lungs do happen very quickly once you start the high frequency ventilation. So it would be strongly recommended to get an X-ray that done within first couple of hours after starting high frequency ventilation, ideally within an hour, so that we can adjust the amount of mean airway pressure. What we don't know, we are assuming the 2 centimeters above the mean airway pressure of the previous conventional ventilation is sufficient to open these lungs up. But at this stage, we still don't know whether that number 12 or 14 is sufficient for these lungs to open up. One of the guides that will help you is the oxygenation. If oxygenation is adequate, that means you will achieve the mean airway pressure. Okay, one of the best way is to stand bedside, increase the mean airway pressure by 1 until you achieve the adequate oxygenation. That is the pressure where you achieve the adequate oxygenation in the small under-recruited lungs is called opening pressures. So open lungs is important so that the lungs doesn't, that's a pressure that you need to open these lungs up. That tells you the compliance of these lungs, whether it's very compliant or very stiff lungs. That will help you to determine what is the next course of action for this baby. Hopefully that makes sense, adjusting the mean airway pressure. So as we all see so far, I'm discussing about the mean airway pressure. It's directly influencing only the oxygenation. It doesn't have much effect on the carbon dioxide clearance, the ventilation. Before I move on to the next parameter, the amplitude, I just want to see if anyone wants to ask any questions. Is that clear to move on to the next one? If anything, please put in the chat box. Give it like 30 seconds, 1 minute. I think you don't have questions. I just want to move on to the next one, which is the amplitude. Amplitude, as I said, it's the amount of air or in and out of the lungs, or the wobble that you want to see. It indirectly tells the power of the ventilator or oscillator. So clinically, we say it's a wobble. When you put the baby on high frequency ventilator, the chest of the baby like wiggles or wobbles, whatever you say. It goes like a tractor. Tick, 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 tick. So how do you adjust the amplitude of the baby when you first start? In a conventional ventilation, the airway pressure waveforms will be like this, whether in inspiration, expiration, or wherever you are it's in the proximal airway, it's in the distal airway, as we discussed before. So the longer the airway, the amplitude doesn't reach the alveoli. The smaller the airway, the amplitude doesn't reach the alveoli. So you want to have the adequate size ET tube, both in the diameter wise and the length wise. Okay. So, and amplitude, as we said, it's amount of air that's going in and out during the ventilation part. Indirectly, we are saying that amplitude mainly governs the CO2 clearance, that is ventilation. Okay. When you want to start the amplitude, how do you set how much amplitude to start? Roughly, as a clinical sign, if you're watching the baby wiggling on the high frequency ventilator, you want to see the wiggle until umbilicus. Until umbilicus at least, when you look the baby in a tangential direction, not from the top of the baby. You need to bend down a little bit and look at the eye level to the umbilicus to see that the wiggling or wobbling of the baby's chest the wiggle should be until at least umbilicus. If it's more than umbilicus, that means you are in the mode amplitude, which you don't need. If it is less than umbilicus, that means your amplitude is not sufficient, you want to increase. Roughly, to start with a number, generally you start double the number of the mean airway pressures. For example, if a mean airway pressure of 12, you want to start the amplitude around 24, and then adjust the amplitude according to the wiggle of the chest while looking at the baby. Further, you can adjust the amplitude based on the blood gas and carbon dioxide clearance for the babies. Just 2 seconds.
Dr. Ranjit?
So the next, can you hear me now? Hello, can you hear me?
Yeah, please continue.
Yeah. So the next parameter in high frequency oscillator ventilation to set up would be the frequency of ventilation. So basically, as we said, the frequency, the hertz is either we say 10 hertz to start with for most of the babies, where you start, which is equal to 600 cycles of high frequency per minute. So in contrary to conventional mechanical ventilation, if in conventional mechanical ventilation, if you want to increase the CO2 clearance, increase the rate, yes. But in high frequency ventilation, it works in a different way. To increase the CO2 clearance, you have to decrease the frequency. So the lower frequency causes more CO2 clearance, and the higher frequency causes less CO2 clearance. So just looking at just with that same phenomenon, so to see where to start, ideally around 10 hertz is sufficient for most of the babies, both very preterms or term babies with various pathologies. But if you want to be more specific, you want to fine tune your ventilation settings. If, for example, you want to see that you don't want to hyperventilate any of these babies, especially if you take a premature baby in the first extreme premature in the first 1 or 2 days. Both hyperventilation that can cause hypocarbia and cause leading to periventricular leukomalacia, or hypoventilation leading to hypercarbia, which can cause to IVH. So both these modes of both hypercarbia and hypocarbia to be avoided for these small babies. And especially in the first 3 days, the more at high risk of what we say intraventricular hemorrhage. Okay, so we don't want hypercarbia for these babies, and because the changes in the perfusion is so much dependent on the carbon dioxide for this extreme premature, you start at 10. For extreme prematures, you can even start at 12, 13, because if you're starting high frequency ventilation mode as a primary mode of ventilation for an extreme premature baby, just remember that it's a powerful ventilation. The CO2 clearance can be very fast, so that can lead to hyperventilation and hypocarbia very quickly. So we would recommend to start higher frequencies for a very small babies, especially babies less than 28 weeks. Very few units practice high frequency as a primary mode of ventilation. But if we want to use that high frequency as a primary mode of ventilation, which do work in some of the small babies where you don't want too much pressures to give. So high frequency ventilation with a frequency around 12 to 14 is the recommended starting frequency for these extreme premature infants. But in a term baby, irrespective of the pathology, it's okay to start most of the times at 10 and adjust your frequency based on the carbon dioxide clearance on the blood gases for these babies. So as we said, once we put the baby onto the high frequency ventilation, we talked about what settings we want. One is the mean airway pressure, amplitude, or which is also called amplitude of ventilation, which is delta P, and also the frequency of ventilation, and adjust the oxygenation based on the FiO2 as well. So to adjust the oxygenation, both mean airway pressure and FiO2, that alters the oxygenation. Amplitude and the frequency is towards targeting the CO2 clearance. So once you put the baby on high frequency oscillatory ventilation, it is giving a clear instruction to the nursing staff, helps you to achieve adequate ventilation, preventing both hyperinflation and under recruitment or hyperinflation of the lungs. So it's important to watch the chest movement if, for example, if there is a loss in the wiggle of the chest, that tells you either there may be a ET2 blockage or ET2 slippage, and the baby can start de-recruiting. And one is watching the chest wall movement, watching the blood gases, doing a chest X-ray, ideally within an hour to start with, at least every 12 to 24 hours, to make sure that you're not under-recruited or hyperinflated. Other things as we need to monitor is the blood pressure, because the high frequency ventilation, we are keeping the alveoli completely recruited most of the times. That decreases the venous return to the heart. That can cause hypotension for these babies. So ideally, before even starting high frequency ventilation, it is important to optimize the blood pressure, and some babies might need more volume expansion or even inotropes after starting high frequency ventilation. If once you start on high frequency ventilation, if the patient is hypoxic or not ventilating, make sure you check the ventilator is working properly, like you put in dope scenario, displacement of the tube, obstruction of the tube, and in pneumothorax, any equipment is working properly. For the high frequency ventilation, specifically things that you want to check, one is the amplitude, the wiggle of the chest, that tells you the ventilation is working properly. If you're struggling with oxygenation, main thing, as we said, adjust the mean airway pressure or the FiO2. If you're struggling with the ventilation, for example, if you have a high CO2 on the blood gases, either you can decrease the frequency, which is in contrary to the conventional ventilation, or you can increase the amplitude. So for high CO2, for CO2 clearance, both amplitude can be, frequency can be adjusted. Decrease in frequency causes more CO2 clearance. Increase in the amplitude causes more CO2 clearance. These things have to be remembered so that we don't get confused when you're adjusting the ventilation. When there is a hypocarbia, you can decrease the amplitude, but at the same time, remember, you don't want the wiggle of the chest to come down less than the level of umbilicus. Because once it goes level of the umbilicus, there is a high chance that baby might start going into de-recruitment phase. If you're still stuck with a very low amplitude, if you're still struggling with the low carbon dioxide, you should switch back to conventional mechanical ventilation and think about extubating the baby. There are situations where you can directly extubate the baby from high frequency ventilation, but most regular practice is changing from high frequency to conventional ventilation. Best way will be the volume guarantee ventilation, and then wean off the volume guarantee ventilation into the CPAP. So when you are weaning or adjusting things, before adjusting the mean airway pressure, generally we say reduce FiO2 to less than 40 before weaning the mean airway pressure, unless until we have overinflation of the lungs on the chest X-ray. Wean the mean airway pressure by 1 to 2 at a time, not more than that. Conventional ventilation, generally we go by at least 2 centimeters weaning every time. Here, ideally we recommend 1 and the maximum by 2. And the amplitude can be changed or adjusted or decreased, increment or decrement between the 2 to 4 centimeters in every time. Frequency is something that generally we tend to avoid, but frequency can sometimes need to be adjusted particularly for the babies who have a prolonged ventilation or very difficult to ventilate, difficult to carbon dioxide clearance, like babies with BPD, babies with PI, pulmonary interstitial emphysema, congenital diaphragmatic hernias, babies with hypoplastic lungs. These are like quite difficult to ventilate. You might want to adjust the frequency for these babies, but generally frequency remains untouched. When the mean airway pressure comes down to around 10 or 8, then you start thinking of conventional mechanical ventilation. If the mean airway pressure, the baby is stable on mean airway pressure of around 8 or 9, it is equal to CPAP. So you can we can extubate some babies directly from high frequency ventilation onto CPAP machine. So what is the nursing instruction that you need to give when you put the baby on high frequency ventilation? Basically about the positioning of the baby, the secretions, the blockage of the ET tube that need to be avoided. And one of the things that we need to remember, whenever the baby needs suctioning, disconnecting the ventilator in high frequency ventilation mode can actually de-recruit the lungs. So it is important to have a closed suction system when the baby is on high frequency ventilation to prevent the de-recruitment of the lungs. Okay, so one of the important things that we need to remember, high frequency ventilation, we need to have the closed suction system that will help to prevent the de-recruitment of the lungs. And you need to instruct your nursing staff and monitoring charts about the positioning of the baby. Again, the prone position do help some babies, but it's not really practiced because most of these babies who are on high frequency also have umbilical lines and central lines. So it's not much routine in practice. Monitor degree of oscillation. Yeah, so it's just the amount of wiggle. The nurse need to keep checking, or the junior doctors, or whenever you're on bedside, you need to keep checking the wiggle is happening. And to prevent the complications of hypertension, the perfusion, the blood pressure needs to be monitored because of the high frequency, the frequency of the ventilation. Most of these babies don't like this ventilation. If the baby is awake, they will fight with the ventilation. Baby can be quite irritable. It's important to have sedation, and some babies even might have to be muscle relaxed to achieve adequate carbon dioxide and oxygenation. And one, as I said, do not disconnect from ventilator. You need to have a closed suction system. So what are the complications that can happen with high frequency ventilation? As I said, the patient might not actually tolerate it. And secretions can be one thing that's commonly to block the ET tube. Over distension is very, very common if you don't do regular monitoring with chest X-ray and looking at the wiggle of the chest. Over recruitment itself defeats the purpose of putting the baby in high frequency ventilation because you're actually causing polytrauma here. Very, very, very high pressures on the high frequency ventilation can lead to pneumothorax. But as we said, this is much gentle way of ventilation compared to conventional ventilation, so the chance of pneumothorax is less. Okay, I think sort of covered the basics of high frequency ventilation and what it works and how to set it up. In the next module, I want to cover case-based discussions, how to adjust the high frequency, when to initiate, how to initiate. Meanwhile, if anyone wants to ask any questions, please feel free. So,
one question.
Yeah. Go on.
What's the role of volume control ventilation?
So as we discussed in the previous session, volume control ventilation is the if you think at it more physiological way of ventilation. Volume control ventilation in the high frequency, there are new modes coming up. The new ventilators give you option of high frequency plus volume guarantee. So when you say volume control, I assume that you're asking about volume guarantee. So volume guarantee ventilation It is the more gentler way because the research is showing the volume trauma is more dangerous than barotrauma for these lungs. At the given amount of pressure, we don't know actually about the how much volume we are going to generate for these lungs because of the change in the compliance. So ideally, if you're putting a baby on conventional mechanical ventilation, it is important to start on volume ventilation, giving a tidal volume around 4 to 6 ml per kilo, and let the machine and the baby decide how much pressure it needs to achieve the targeted volume. Okay, so volume ventilation is more gentle way. It prevents the volume trauma, and also it helps the clinician for us, helps us to decide where, because it's like auto weaning mode. When compliance of the lungs increases, automatically the machine will give less and less pressures. It will tell you that okay, the baby is ready to extubate. If that answers your question.
So Ketan has sent a thank you to you, sir. And it was actually being done in such a beautiful way that HFO being made simple. It should be that rather than putting it as advanced ventilation part 1, it should have HFO made simple. Other question is difference in flow trigger and pressure trigger and which is better?
So obviously, like the flow trigger is more simpler and easier for the babies to achieve. For example, if you see the pressure trigger modes, the baby has to achieve adequate amount of pressure to trigger the ventilation, which most of the very extreme premature babies might not be able to do that. That's why all the new modes of ventilation are flow triggered modes. The flow sensor in the on the ventilator circuit senses the flow, expiratory flow of the baby, and synchronizes the ventilation. And also the flow also triggers the ventilation in some certain modes like SIPPV and SIMV. So flow trigger would be again more physiological, more gentler modes of ventilation. Pressure trigger ventilation is actually going out of fashion now because the pressure trigger, the most of the smaller babies what we ventilate won't be able to achieve the pressure trigger ventilation.
If there is any other question, please put it on the chat box or you can share it with me. I'll share it with Dr. Ranjit. With this, as there is no other question, we'll close this session.